Hello, good evening all. Hello to all my Fmge friends. I hope my voice is audible and the video quality is fine. Welcome all to the session of ENT recall. Roughly around 17 to 18 questions as per the recall what I've collected from all the students that could recall all the questions. Roughly around 17 to 18 questions have been inculcated in this particular session. Within just 1.5 minute, I'll start with this session. I hope my voice is fine. Any doubts, you can write it on the chat box. And if there are any doubts later also, you can connect me through Instagram. Fine. I hope everything's fine. With this, let us start with this session of ENT recall. Any doubt, feel free to ask. And just before starting, I want to say just one very important thing. Whatever has been done. I know it has been repeated number of time by many other faculties. Now is the time to relax, enjoy, spend time with your parents. Fine, I won't waste much of your time and start with this session of recall. First question that I have got from many of the student is: a patient had presented with lung injury and tympanic membrane rupture following a blast exposure. What is the most probable level of injury due to this blast wave effect? I expect some of the people would have answered it correctly. Actually, this is a question more from the general surgery side. In surgery, it is being taught more what are the levels of injury: level 1, 2, 3, 4, 5, and beyond. Still, if you know, well and good. If you don't know, I'll add to it. Basically, what happens, beta? Remember, whenever there is a case of a tympanic membrane rupture, with or without, remember, with or without abdominal injury due to blast, remember, with or without any chest trauma, lung injury, basically lung injury. This basically is level 1 trauma. Remember, this basically is level 1 trauma. Going to level 2, bache. What is level 2 and beyond? What is level 2 and beyond? This is very important. Level 2 is basically, bache, penetrating traumas, like bullet injury most commonly, penetrating. Then we go to level 3. Level 3 basically means, level 3 is simple, basically your fractures and blunt trauma. Fractures and blunt trauma come into level 3 type of injury. And then level 4 and beyond onwards is basically simple. It is basically burns and radiations. Burns and radiations come in level 4 and 5. 4 is more towards burns, and radiation exposure comes more towards 5. So these are the levels of injury. I know it's quite a rare question, but it has come more from the surgery side. But yes, they had included the tympanic membrane part, so we had to discuss this particular question. So this was the question of levels of injury. If any doubt, you can ask. If everything's fine, no problem. Fine. With this, we'll move to the next question, beta. Next question is: a patient presents with a fishbone stuck in the piriform sinus. During the removal of the procedure, during removal of this particular, fishbone, some sort of accidental nerve injury has occurred. Then tell me, what is the most common nerve that is affected? I hope you would have marked it correctly. Better let me clarify this very important fact. We know that vagus has two branches. One is superior laryngeal nerve, superior laryngeal nerve, and then there is recurrent laryngeal nerve. This is the way how it supplies larynx. Superior has further two branches: external branch and internal branch. Fine. Remember, external is the motor branch. External is the motor branch. Internal is the sensory branch. Fine. External branch of superior laryngeal nerve is motor and internal is sensory. And then recurrent laryngeal nerve is both sensory and motor. Now, they have specifically said piriform sinus. Better remember piriform sinus and supraglottis part of larynx. Piriform sinus and supraglottis get their sensory supply directly from internal branch of superior laryngeal nerve. It has been repeated number of times in the class also. If you have been a regular student, that internal branch of superior laryngeal nerve is a sensory nerve supply for supraglottis, that is the uppermost part of the larynx, and the piriform sinus. Piriform sinus, if you don't know, I'll tell you, piriform sinus is a part of hypopharynx. I hope you know in classes also I repeat this fact that hypopharynx is divided into three P's. You might be knowing. One is posterior pharyngeal wall, second is piriform sinus or piriform fossa, and third is very famous post-cricoid region. Fine. So remember, piriform sinus is basically supplied by the internal branch of the superior laryngeal nerve. This was the question asked, a direct question that has been asked. Fine. Now going to the next question. What is the narrowest part of adult laryngeal airway? Better directly notes question it is. If you see in your notes itself, I quite often repeat this particular fact. In the notes itself, you might have seen that I particularly give a table and I say that between children and adult, they'll ask only two questions: level of larynx and the narrowest part. You can check your notes also, and it has come directly from that particular part only. You might be knowing the narrowest part in adults is bache glottis, and in children it is subglottis. Fine. Narrowest part in adult is glottis. If they would have asked children, then it would have been subglottis. Fine. This is the narrowest part of adult laryngeal, airway, that is glottis. I hope this particular part is also clear. Direct question. Fine. Going to the next question. What surgery is being performed in the given image shown? Which see simple. Again, if you check your notes, I will specify one thing. In your notes itself, I particularly teach one image where I say that we give a incision starting from philtrum till the medial canthus of eye. Fine, which is a very famous Moore's incision, lateral rhinotomy or Moore's incision. Why it is given? And if that incision is extended here, then it is called as Weber Ferguson incision. What? Weber Ferguson incision. Why are these incisions basically given? They are given for a procedure called as maxillectomy. But you yourself see, if they have elevated whole maxilla, what it can be? It can be maxillectomy. It can never be ethmoidectomy. Fine. It can never be ethmoidectomy. It can be only one thing, that is maxillectomy. So you had to choose between two options only: total maxillectomy and partial maxillectomy. Why total? Because if you see what image that students have said that they had elevated both sides flaps of maxilla. So that will be total maxillectomy. You could have recalled from this particular image. In your class notes itself, I give this incision Moore's and Weber Ferguson incision. For maxillary sinus carcinomas, they are quite often used. Fine. So this image was basically of a total maxillectomy, and that was the procedure or the surgery that is being done, that is being shown or depicted by this particular image. Fine. Going to the next question. Very tricky question, I must say. Human papilloma virus infection is most strongly associated with which of the following head and neck cancers? Better believe me, if this sort of a question was asked, I would have gone for both, either oropharyngeal carcinoma or it can be laryngeal carcinoma also. Fine. Let me be very clear that HPV, that is human papilloma virus, is very commonly associated with both oropharynx and laryngeal carcinoma. But why I am going more towards oropharyngeal carcinoma, I'll tell you the reason. But what happens that laryngeal, basically, laryngeal tumors or laryngeal papillomatosis is more commonly caused by the milder strains of HPV, that are 6 and 11. But if you talk about oropharynx cancer are basically caused by HPV 16, the strain which is 16. 16 are, causing more malignant thing, and they had given as cancers. Options were given as cancers. So considering cancer as, the question asked or the option given, I would go for oropharynx. If they would have asked for more like benign tumor or papilloma, then laryngeal was a better option. Otherwise, I would say for the students who have marked laryngeal also, they were not wrong in the thinking part. I mean, oropharynx and larynx both can be a correct option. But why I'm going for a better option, that is oropharynx? Because larynx is more commonly associated with milder strains, that is 6 and 11. I mean, more benign lesions. But oropharynx is more commonly associated with oropharyngeal carcinoma, that is HPV 16 strain. I hope this particular doubt is clear. Otherwise, my sincere, what deepest condolences for all the students who would have marked laryngeal, because they were not wrong. I mean, I will definitely say that larynx is also quite associated with HPV, but HPV causes more of benign sort of lesions in larynx by strain 6 and 11, but 16 more commonly causes cancer, back to particularly in oropharynx. Fine. Next question. A professional singer presents with difficulty in raising the pitch of his or her voice following thyroid surgery. There is no hoarseness, but high pitched voice production is impaired. Basically, the problem is that singer cannot sing properly. That means vocal cord cannot come close to each other. Which nerve is most commonly affected? Bit C. Simple. In class itself, we repeated multiple times that there are two main muscles of larynx. One is cricothyroid, which is responsible for adduction, basically voice. Then second is PCA, posterior cricoarytenoid, which is the only muscle for abduction, taking away, mainly breathing, mainly responsible for breathing or respiration. Fine. Now, they say that there is a problem in singing. Basically, there is a problem in voice. So, if there is a problem in voice, the person cannot speak or person cannot raise his voice. The problem or the muscle involved is cricothyroid. Simple, cricothyroid is the muscle involved. That is clear. Now, sir, which nerve is involved? If you remember, beta, we always say all muscles of larynx, even posterior cricoarytenoid also, is supplied by recurrent laryngeal nerve, except for, if you remember, except for which one? Except for cricothyroid, that is being supplied by the external branch of superior laryngeal nerve. Except for what? Cricothyroid, which is supplied by external branch of superior laryngeal nerve. I hope this question is simple and clear. Beta, problem is in voice. That means which muscle is involved? Cricothyroid. And what is the cricothyroid nerve supply? External branch of superior laryngeal. Simple. Fine. I hope this question is clear. If they would have said that there is a problem in breathing, that means abduction muscle is involved, PCA is involved. PCA is supplied by which muscle? Recurrent laryngeal nerve. Fine. But now in the question, they are saying problem in singing. That means singing muscle is basically cricothyroid. Fine. Going to the next question, beta. Yes. There is an image shown with a lateral view of face with a highlighted region, particularly in front of ear. What type of abscess is most commonly indicated in this particular region basically? But you might be knowing in CSOM complications. Open your notes to CSOM complications. I discussed some few common things. What first is what is Bezold abscess? Bezold abscess is the abscess in basically sternocleidomastoid muscle. Then what is Citylis abscess? Citylis abscess is basically the abscess collection in the digastric muscle, particularly the posterior belly of digastric. Then what is Luke abscess? Luke abscess is basically deep meatus abscess. In the deep bony meatus is Luke abscess. Now look at this region. Better this region, if I magnify, is the zygomatic region. So what type of abscess is this? comes the last fourth option, that is zygomatic abscess. That's why the correct answer for this particular question is zygomatic abscess. I hope this particular question is also clear. Fine. Now, I don't know. Many students said that such type of question was not there. Some students said that, no, sir, there was one particular type of question here. And this question is, a patient presents with an ophthalmos with ecchymosis around the eyes, and the person was hit by a ball. What is the most likely diagnosis? It's a very famous thing. You might be knowing some sort of teardrop sign in radiology we discussed for this particular question. And what is that? That is orbital fracture. Basically, what happens most commonly, the floor of orbit. Remember this. This is the floor of orbit that gets damaged, and it ultimately leads to in ophthalmos. The eyeball gets pushed inwards, and there is periorbital ecchymosis. This is a very famous question for orbital blowout fracture. Bit of simple. It cannot be Leaford type 1 because Leaford type 1, you remember, it runs low towards the maxilla. Nasal bone fracture, they would have shown some problem in nose, basically swollen nose, fine, or deviated. Zygomatic is seen in the lateral part, fine, in the lateral half of the face. Right now, they are showing it towards the orbit part. That's why it is going more towards the orbital blowout fracture. Fine. Next question. The tip of the uncinate process is typically seen attached to which of the following structures? These were the options. Fine. One student has asked, in fact, is telling that teardrop radiographic image there, sir, not real image. Then it is for this particular question, if they would have given teardrop sign bache directly, then though it is even more evident than this particular image. It is more easier to diagnose teardrop because it is shown by the radiology faculty also, by the ophthalmology faculty also. If teardrop radiological image was given, then it is very evident that you would have and you should have marked or vital blowout fracture. Fine. I hope it is clear. Then question is, the tip of the uncinate process is typically seen attached to which of the following structures? But if you remember in the class itself, I say that there is something very important that is called as osteometal complex, which consists of three parts. One is uncinate process, second is hiatus semilunaris, third is infundibulum. If you remember, fine. In which region? In the middle meatus region. In the middle meatus region. But right now, what they have asked is that uncinate process is attached to which of the following structures? That will be with a middle turbinate. If they would have asked that, osteometal complex, if they would have asked, or uncinate process location is at which particular part, then you could have marked middle meatus as the answer, and that would have been the better option to be marked. But if, and most students have confirmed that it was, the question was the, or the, superior most attachment of uncinate process is where, then the answer, bache, will be middle turbinate, not middle meatus. Fine. I hope this particular question is also clear. Next question. A patient presents with a history of fall and is found to have bleeding from the ear on definitely examination. What is the investigation of choice? But all the students, if you remember, I always say in class also that investigation of choice for most of the haddi problem, most of the bone problem is always CT scan. Investigation of choice for most of the haddi problem or bone problem is most of the time CT scan. If you would have not known also, then you could have thought about CT scan. But right now, if they're talking about ear bache, obviously will not go for CBC. X-ray mastered rarely gives some sort of a good diagnosis. There could have been two options: MRI brain and CT temporal bone. Obviously, it's a damage to the temporal bone part. The CT scan would be a better option than MRI brain. Hence, the answer is CT temporal bone. Obviously, they are specifying more towards ENT part, ear part. So, CT temporal bone is a better option to be marked rather than marking MRI of the brain. Fine. Yes. Fine. Next question. A male, a male patient presents with high frequency hearing loss that worsens in noisy environments. That worsens in noisy environments. What is the most likely diagnosis? A male patient presents with high frequency. Beta, if you know, if you have seen the 25 most important session that I had discussed some days back, in that particular part also, I had repeated that this PTA question will come, will come, will come. I had repeated in the 25 most important session also. I had assured you also that a question on PTA will come. You can check the video, and I had listed that question on this tympanogram will also come, and both those questions have come. And in fact, if I am recalling it right, three questions came from this particular audiometry, and I had told in the 25 most important session also that 100% they will ask, because it's a trend in FMG examination that they are asking audiometry for sure. Fine. Again, the question says a patient, a male patient. I think they had given age also. Some students had said that they had given 75 or 80 years old, obviously old age, presents with high frequency hearing loss that worsens in the noisy environments. What is the diagnosis? But if you remember, this is a rising curve for what? Meniere's disease. Meniere's disease is basically a low frequency hearing loss. Fine, but they had mentioned high frequency. What is that particular graph? If you remember, down sloping curve, what was it for? It was for presbyacousis. A down sloping curve is for presbyacousis. Why? Because at higher frequency, this is intensity, this is frequency. At higher frequency, there is hearing loss. You can see at higher frequency, there is hearing loss, hence higher frequency hearing loss seen in presbyacousis. Fine. I hope this particular part, this particular thing is totally clear with all of you. Fine. Next, very direct question, very repeated question. My deepest, condolences for the student if they would have made this question wrong. If this question has come, a diabetic male patient presents with facial pain and blackish discoloration, bone erosion, sinus involvement is shown without even seeing the image. Don't even read the image, don't even see the image. You just see. I always repeat this in class. Diabetes and nose, it is mucormycosis. Diabetes and ear, it is malignant otitis externa. Diabetes and neck, more commonly Ludwig. Second is parapharyngeal abscess. Now, right now, they have asked diabetes and nose. What is it? Bit of simple, it is directly going towards mucormycosis. Although they have given more features like blackish discoloration present in the nose, facial pain, and sinus involvement, bone erosion, going towards, yeah, fine. Very rightly said. Diabetes and nose together, but it can, they will not ask any other thing rather than asking mucormycosis. In the second wave of COVID, most of the Indians know that India was definitely suffering from this particular disease, mucormycosis. What is the drug of choice? Liposomal amphotericin B. Fine. Going to the next question. A 60-year-old man complains of gradual, hearing loss over the years. He reports difficulty hearing conversations, especially in noisy surroundings. I hope, I in fact think that it is sort of a repeated question. Fine. There are no episodes of vertigo, tinnitus, or earfulness. If this particular, question has come, it is again going towards presbycusis. Direct question, beta. Repeated question. It was told in your 25 most important session also. While discussing Pureton audiometry and tympanogram, I had emphasized these particular things. You can check the video also, and I had told in that session also that this will 100% come. Again, I hope so, and I wish so that you would have marked it correctly. Coming to, yes, tympanogram has come. A tympanometry graph was shown and arrow was indicated. Fine. What is the most likely diagnosis? Beta, if you know, this is the graph between the compliance and pressure, where this particular thing at zero is basically a, that is normal. If it is shallow means depth is low. ASS actually stands for shallow. I know you remember it as autosclerosis. Again, in 25 session, I told you, but a S means shallow. The graph is below shallow. And if the graph is like this, peaked up, it is AD. Why? Because the graph is deep. Discussed, already discussed. Fine. So this was AS that they had asked if this tick was here. Other graphs are basically B and C. Where B is a flat curve like this, which is seen in which condition? Serous otitis media, also called as otitis media with effusion, also called as secretory otitis media. All things are the same thing. Serous otitis media, secretory otitis media, or otitis media with effusion, all three give a flat curve. Fine. And serous otitis media is more commonly seen in which nose problem in children? Adenoid hypertrophy. All of these questions have been asked. Fine. And lastly, there is a negative graph where the graph shift towards left, and that particular thing is what? C type of graph seen in eustachian tube dysfunction. Fine. Eustachian tube dysfunction. Anyways, they had asked AS type. I hope you would have marked it correctly. Yeah, fine. Dr. Harshali is saying that there was only one question about presbycusis. Perfectly fine. Fine. The only question, in fact, among all the questions, beta, right now for all the students who are listening to me, among all the questions that NB had asked in this FMG examination, the only question which I'm, not sort of comfortable with, or I should not say that it is not a perfect thing to be asked. Why? Because the question says the patient presents with stridor and cannot be intubated. Fine. What is the most appropriate next step? Better the answer should have been, in fact, the option should have been only one thing, that is tracheostomy. That should have been the option, and that is actually the answer. But because they had not given tracheostomy, because they had not given tracheostomy as the option, very, sadly, I would say that this particular option has to be marked. Otherwise, I'm very firm on this. We operate it almost every day, in the hospital. And in fact, today itself, I had done it in the morning. That tracheostomy is done, but a cricothyroidotomy is obsolete. It is not done. Fine, tracheostomy should have been the correct answer, but because tracheostomy is not in the option, then cricothyroidotomy is the option you could have marked, because ultimately a cricothyroidotomy is converted into tracheostomy later on. Fine, you cannot go for nasal intubation. Obviously, if the patient cannot be intubated, nasal intubation cannot be done. Same with bronchoscopy and laryngeal mask airway. All these are totally incorrect option. But I feel that tracheostomy should have been given as the option rather than giving cricothyroidotomy and just confusing out students. Because cricothyroidotomy is almost never done. Almost never done. It's an obsolete procedure. We never do it. Fine. Tracheostomy should have been the correct option. But still, if it is not given, then cricothyroidotomy you could have marked. Next question. A 5-year-old child is brought to the OPD with mother, and the mother is saying that the child is having poor school performance, recurrent ear infections, tympanic membrane is dull and retracted, and fluid is there behind. There is no blood clot present. What is the most likely diagnosis? Beta, simple. Poor school performance, recurrent, ear infections, and the tympanic membrane being dull. Mostly, these are the children who are actually suffering from mostly adenoid hypertrophy. And because of adenoid hypertrophy, they ultimately land into serous otitis media, also called as otitis media with effusion, also called as secretory otitis media. I already told you all these are the same things. And what type of graph you will get? It is a flat graph, flat curve in tympanogram. So the correct answer is otitis media with effusion, not cholesteatoma or acute otitis media or external. I hope this particular option is clear. Otitis media with effusion or serous otitis media is the correct answer that should have been marked. Some student had told me that similar question was asked, the same sort of clinical picture, and they had asked what type of tympanogram you will see. What type of tympanogram you will see? I've already told you, you will see a B type of tympanogram. B type of tympanogram. Fine. Now, beta, if you know, fine. If you don't remember, obviously some days have passed, you might not be remembering it. I have been informed by some students that a question on stapedial reflex was asked. Let me tell you some brief important things regarding stapedial reflex. Better remember, stapedial reflex is seen at greater than 70 decibel. First famous question is this. Secondly, what are the afferent and efferent of stapedial reflex? What are the afferent and efferent? Remember, beta, eighth cranial nerve, that is your auditory nerve, is the afferent, and efferent is bache facial nerve. You might be remembering facial nerve has a branch called as nerve to stapedius. There is a facial nerve supplies stapedius muscle. Facial nerve basically supplies this stapedius muscle via a branch called as nerve to stapedius. So that particular efferent question, some students told me that this has been asked. If this has been asked, then facial nerve, that is the seventh cranial nerve, would have been the right option if asked. If not asked, well and good. Some students had told me that a question on stapedial reflex had also come. Apart from this, I don't think so there can be any other question from stapedial reflex that can be asked. Next, some students told me that a question strider had come. That what type of strider, some students told me that a question on strider had basically come. So bache, remember strider is high pitched breathing or noisy breathing because of respiratory efforts. Patient is having problem or obstruction while breathing. So remember strider is of three types: inspiratory, expiratory, biphasic. Remember, inspiratory seen in problem of supraglottis, expiratory seen in problems of trachea and lungs, and lastly biphasic is seen in glottis or subglottis. If asked, well and good. If not asked, perfectly fine. If it was asked, I have included it. Yeah, Dr. Harshali again, she's saying that inspiratory strider was there was a question. So if strider question would have come, it would have been this question only. So if they would have asked inspiratory strider, then you should have been marking this particular option, that is supraglottis, if asked. And lastly, one more question I had received. Some of the students had said that they had shown a tracheostomy tube and they had marked towards cuff. I hope you remember what is that cuff or balloon. And they had asked, what is this cuff of tracheostomy tube, useful for? What is the role of this cuff part or the balloon part of the tracheostomy tube? Remember, this cuff or balloon is basically only for one reason, that is prevention of aspiration. That is the most important fact, that this cuff is mainly responsible for prevention of aspiration. Fine. One student is asking, when will the results come? Beta, I don't know what will be the result or when will the result come. The only thing that I can wish for is most of you, maximum of you, in fact, all of you pass this particular examination with flying colors, and hope we meet together while preparing for NEET PG examinations. I just want to say thank you so much. I wish you all the best luck. Live a very good, happy, and a healthy life. Thank you so much. Jai Hind. And lastly, just before leaving, if you have any doubt, you can message me on my Instagram ID ent underscore by underscore dr dot shubham. Thank you.